on how to transition to value-based care. And I think it's a good follow-up to the keynote speaker from Village in Indeed. I was impressed by that presentation and felt like there's just a lot of initiatives going on for value-based care. And not everybody sees the world the same, and I think some of that will come in our panel discussion so far. So again, welcome to the session. I want to introduce our panelists, and sitting next to me is Dr. Brent Staton, and he is the CEO of CCHI, which is
Cumberland Center for Healthcare Innovation.
I can never remember that, what Brent said. And then Rachel Corbitt, down there. Rachel is the Executive Director of Primary Care Alliance ACO in kind of the Central Florida area, Mount Dora. And then Phyllis Wojtusik, okay, and she's the Executive Vice President of Health System Solutions for Real-Time Medical Systems for a impressive company. So wanted to do that, and then some of you, maybe all of you by now, have a copy of the handout, and I wanted to explain that handout. So I'm John Schmitt, Executive Vice President of the ACO Exhibit Hall, soon to be the Value-Based Care Exhibit Hall. And I was doing a lot of consulting work for the last 20 some odd years before we started this virtual exhibit hall. And I think, it was just very interesting to be able to see this transition in healthcare that we're experiencing. And that's in large part what we're going to be talking about as a panel. That handout that you received is the result of surveying all of our advisory board members. We have 16 ACO executives or consultants on our ACO Exhibit Hall advisory board. And every year when we do this session, we send out the questions in advance to them. So what you see is a summary report of all of the responses that we received back from our advisory board ACO execs. And Rachel did double duty. She responded to the survey, and she also was here on the panel. And Dr. Staton here is also an advisory board member as well. So all of that said, I wanted to just go ahead and get started. I realize we're running a little late. We only had 45 minutes to where it was, so we'll probably run over a little bit on our end as well. So let me get started. Most of you have that handout. And I will mention that, first of all, Real-Time Medical, which is Phyllis's company, is also sponsoring this panel session. And again, really encourage you to go to the ACO or directly to their Real-Time Medical website and meet with the company. They do a lot of good stuff. Okay, we'll skip over here. I did the introductions and all behind it. Okay, so this is question one. And I'm going to read it from the handout since I can't read sideways. Physician and clinician engagement has proven time and again to be the secret sauce for value-based success, regardless of the complexity of the contract. However, it takes more than physician and clinician champions to enable value-based care. It requires infrastructure. And the question here for the panelists was, what infrastructure resources do ACOs need to enable successful value-based contracting? And I'm going to go kind of in rotating alpha order, so everybody gets a chance to go first. And in alpha order, then Rachel, I'm going to ask you to be the first one to answer that question. What infrastructure resources do ACOs need to enable successful value-based contracting?
So I don't think there is really a secret sauce. I think it really depends on the organization, on kind of where your focus is. Clinical physician leadership is probably the most crucial to get other physicians engaged, just like Dr. Asplin was talking about in the keynote, that it's crucial to have that physician leadership and engagement. I think actionable data, there's so much data that you can pull and look at and slice it in so many different ways, but having it actionable is key to give something for the providers to look at and actually do something with. And so building those relationships and having the physicians understand that they trust the data, trust you as an organization is probably kind of where we focus on a lot. And then, just taking care of the patient, so nurse, clinical care management, utilization management, things along that clinical management part would be kind of where I would say our ACO has really focused on.
Thanks, Rachel. Brent, I'm going to ask you to weigh in next, but I also want to mention the fact that Brent Staton, not only a personal friend of mine for years, but he's become one of my heroes. Several months ago, I think maybe in the springtime, he contracted COVID, serious case in the hospital for weeks. Finally got released, spent quite a bit of time, but then wanted to get back to his medical practice. So he's still on oxygen, but still sees patients every day. So, really proud to be your friend.
So for an ACO standpoint, we had trouble on it if you look back in our history, initially whenever we started, because what you refer to as actionable data, I use a different term, actionable data. So, I can provide actionable data all day long to give to physicians, but keep it very limited what you put in their hands, because they don't have time to peruse a full 80-20 list. Give them what they want, focus what you want them to focus on. So, whenever we measure things, CMOs here as well, we have a quality index and performance index to measure what's important. And that's how you build your actionable data and limit it as much as possible. Our infrastructure was rebuilt. It was kind of initially built as a central-based organization. We rebuilt it, Dr. Webb and myself, where we took over in 13, 14, something like that, to include physician buy-in, move to practice buy-in after you get physician buy-in, and then patient buy-in. So every patient that walks through our doors understands that we're in an ACO and what that means for them as far as healthcare. So for me, the infrastructure of an ACO begins with the patient as much as it does the physician. We've got a care coordinator here in-house with us as well from our organization. Our patients now are calling us saying it's time for my annual wellness visit. It's time for me to come in and get my labs done. It's time for me to do this. So it's really probably a 5-year training process through infrastructure development, through multiple organizations. We're in about 85 counties in the state of Tennessee. We bleed over into Kentucky a little bit, Alabama, Georgia just a little bit. So we're a large organization, but at the top we're a small group. So we've got about 1,000, 1,200 employees throughout the organization. But at the top of the group, it's very limited, because that's not where the work needs to be done. All the money doesn't need to be concentrated in administration. It needs to be concentrated at the practice level whenever you're developing your infrastructure.
Thanks, Brent. So the next person we want to ask to weigh in on this is Phyllis. Phyllis has more experience than just being with real-time medical, right? I mean, you've been on the other side of the fence here, and been medical practices and ACO experience as well. So given that, Phyllis, we really have to weigh in on this question.
Great, thanks, John. So, as John mentioned, I come out of an ACO background and large health system. So this topic is near and dear to my heart. And I'm going to be in the middle of these two, if you will, both literally but figuratively. So data is obviously important, because you don't know what you're doing if you don't have it. But John's point about the small administrative team, you all need to be pulling in the same direction. So the engagement at your physician and your clinical team needs to come from that small administrative team. And so focusing on what you're going to change over that next year and get everybody pulling in that direction. And I think including the patients and the education is key to that. But I would say on the data analytics side, if you don't have the tools, you don't know what you're missing. And so at some point, you need those tools to look over your entire population. Find some of those easy wins first. Getting your AWVs done, to John's point, or to this point, and making sure that you start with clinical standards and deploying those standards across your network so that you're all practicing the same way. You don't treat every patient the same way. You treat patients as individuals, but you do utilize clinical standards across your network. So data, pulling in the same direction, and those clinical standards, I think, are really a key to how you manage your population.
Thanks, Phyllis. On that handout you got on the second page, I'm just going to read you a little excerpt from one of the responses that I thought was really effective as well with respect to infrastructure. This one was contributed by Ashley King, and all the contributors are on the last page of this handout. But she writes, ACOs must lay the groundwork to create the proper infrastructure to manage populations. Key infrastructure components must support annual wellness visits, disease management, transitional care management, high-risk care management, risk coding, and applied analytics. And each of these requires having sound data, and mechanisms to aggregate claims and other payer data across value-based contracts. From there, it takes the ability to turn the number into insights, which forms your population health strategies. And that's what all of you are talking about, really, is using that data in the infrastructure for insights. Okay, so we're going to go to the second question. So this question is very interesting and timely. How has COVID-19 advanced or inhibited the value-based care movement? In that regard, how can providers and payers improve upon their pre-COVID value-based care models? Before I hand it over to the panelists, I want to read an excerpt from one of the latest modern healthcare articles that I thought hit the nail on the head. I'm just going to read you a couple paragraphs from it and pass it on to our panelists. But it says medical professionals have decided to retire early, take breaks from the field, leave the business completely, as it passes on the past 19 months weighed in heavily on them. That in turn puts pressure on the employees who remain, who are already working long hours to deal with the surge driven in large part by people who aren't vaccinated. And their hospital, St. James Parish Hospital, is about 20% short on their nursing staff already. And so they have tried basically everything to raise morale and make clinicians feel appreciated, from increasing pay for nurses and providing incentives to providing mental health services and massage. People are committed, and I know they're committed, but they've been doing this now for 19 months, and a lot of people are like, once they get the hospital through this, I'm going to be done. Brent said. The situation is pushing people to make those decisions as to whether or not they want to keep working in the environment. But that was an important element of what we're talking about with respect to the impact of this COVID-19. So Brent, we're going to start with you this time to respond back to that question.
I think just from an on-the-ground in our practices standpoint, what's really changed for us, and it's kind of interesting because it's kind of changing back now, was, of course, everybody's going to go, yes, telemedicine. Some people love it, some people hate it. Some patients love it, some people don't. We have difficulties in the regions that we are because we purely focus on rural Tennessee. We have some micropolitan regions as well. This one that I live in, and Dr. Webb would have more of the rural. We still have horse and buggies that come to practices. We have people in our practices who live in dirt floor homes. So we really get down to the base of taking care of these folks. They don't have telemedicine capabilities. They don't have iPhones. They don't have, internet. Most of the people, there's a large component of our communities that don't have the high-speed internet that's necessary for telemedicine. So that was a component of the change that we saw. One thing that I think, really helped our practices the most were, only I know the word is, my brain's brain fogging right now, is drive-through medicine. McDonald's, okay? So drive-through service that we built at our different facilities. If you have any symptoms of illness, you stay in your car. We come out to you. You don't come in the building. And that really has, in my practice, rolled over into taking care of some very difficult patients who are in our very value-based care models, who have difficulty getting into our practice, whether it be wheelchair or weight, disabilities, etc. We're actually going out to them now more so than we ever had. We did before, but that component has grown a little bit more than not, and it helps us with the value-based care models because they're in those models. So having those, it's almost like we've changed our mentality that we're from room to room to room to room all the time, which is what we are pretty much practicing. You know, and all the value-based care models all have fee-for-service as far as a component of it. So we're not in a true value-based care environment, regardless of kind of where we go. And you know, it's just difficult to kind of have that thought process. But the value-based care drive-through medicine for me has probably been one of my favorite advocate movies.
Well, these service areas are so different, aren't they? You know, Miami versus where Brent is working. So anyway, we're going to let Phyllis, I think you're next to weigh in, if you would, about the impact of COVID on the value-based movement.
Sure, thank you. So, unlike the previous experience you just heard about, many of the populations I work with were in a very urban setting. And early in COVID, we saw just populations, particularly in long-term care, which is a big focus for us, devastated. And the separation that patients and families felt during that time was truly heartbreaking. Whether it was hospital or SNF. And so we saw a lot of mistrust, if you will, on several sides. One, people didn't want to go into skilled facilities because they were afraid that's where they would contract COVID. We all know about the New York issue and how numbers were changed or not, things weren't transparent. And I believe that just drove a huge amount of mistrust. And actually, we just had a conversation as we were sitting here. One of the big issues that we saw was that vaccines were not distributed to primary care providers. And I believe that was a huge mistake because people have trust with the relationship that they have with the primary care provider, and cutting them out of that process, I believe, was extremely detrimental. As we move forward, I think telehealth is here to stay. Obviously, it doesn't meet everybody's needs, so I love the drive-through doctor's visit. I think that's awesome, or buggy through, whatever it is. So I think we are going to have to be more creative over time to meet our individual population's needs, whatever that is, wherever they are. Value-based care is not going away. We are going to continue to see it. It is up to us to create that future. One of the other pieces of conversation that we had was, we're seeing big tech really come into healthcare. And to me, as a nurse and clinician, that is really sad. We have not been as creative as we need to be to deliver healthcare in the way it should. So I think COVID has exposed us in ways we never thought about. I think it has pushed us in ways we never thought about. And hopefully we will learn from it and continue to be creative on how we deliver care to our populations.
Rachel, you're up next, please.
So I'm torn with this question because I see some providers have really kind of taken advantage of what COVID had provided with the value-based care, where capitation has saved some of those practices and were able to keep their doors open and continue to see patients. And then you have some of the specialists and other ancillary services that really struggle throughout lockdowns and just varying degrees of patients not coming to their offices. And so before COVID, specialists and other ancillaries were on their way to value-based. It was a slow journey, and so I think some of that has really halted some of the specialists because they're trying to recover financially from not able to have those procedures or have those patients in the office, and trying to create revenue from hopefully nothing, but it seems like they're creating revenue from nothing. And so I think it's kind of a torn mix between, some heavy value-based payers with those primary care physicians really are going at it and going strong and want more of the value care because they see and understand how it kept them alive, versus others are like, nope, fee for service all the way and going strong at it. So I guess I'm torn on that, depending on the provider.
Thanks, Rachel. Brent, you have comments.
I just have a really quick comment. Our ACO has an emergency fund, if you will, and we developed that in case something like COVID happened, because our number one goal was to keep primary care practices in rural America alive. That's our mission, essentially, as an ACO. Because with hospitals closing like they are, you can't get primary care physicians to move into these communities anymore. So who we have there, we need to keep them. So we were able to disperse as an organization to our practices a couple of months worth of overhead, essentially, to every practice in ACO from our emergency fund that we're rebuilding. You can probably tell them from Tennessee emergency fund all the way. This is kind of how we think. But it was helpful. It came in line, and that's, to me, that goes back to your infrastructure question from the beginning. Is you have a mission. Well, how do you accomplish it? There's so many steps we can talk about just that question for an hour. So that's none of our practices closed in our ACO. None of them had hardship. They were able to pay every person that was there. A few folks decided to take some time off from the practices to kind of alleviate, but that was mostly by choice from the nursing staff. So we're you set your missions and your goals, and you build your infrastructure and planning around.
Great, thank you. Okay, let me go to question number 3 here. This is also a very interesting question. And it says, I'll read this one, it's on your handout as well. As practitioners participate in more value-based care arrangement, more of those participation, their patients benefit. One reason is because doctors now have more time to discuss their patient's conditions along with other contributing factors. And those factors are things like the social determinants of health, very important aspect. Given the inherent benefits of value-based care, the question is, what could accelerate the movement to value-based care health models that pay providers for value rather than volume? What could accelerate that? Phyllis, this time we'll start with you.
Great, thanks, John. So I think there's a couple of things. I just actually read an article that came out of CNN saying that in the next 10 years, they want every Medicare patient to be in a value-based program, whether that's an MA program, ACO, whatever, everyone, and they want the majority of Medicaid to be in as well. So one, policy is going to influence that, I believe, and reimbursement strategies that come out of that. But two, I think medical consumerism can also be a driver of that. And I think, we have the silver tsunami that we're talking about. Boomers are not what their parents, that greatest generation, are, where they just accepted everything. They have pushed the limits at every life stage they've been in. So I think the population itself will drive some of this. So between legislation, between providers getting more comfortable with value-based care and understanding what that brings for them in terms of the ability to care for a patient and their satisfaction with that way instead of the churn that we've all seen. Hopefully that leads to increased satisfaction and decreased burnout. Although with COVID, we're not quite there yet. So I think the market itself will drive some of that. Thank you.
Thanks, Phyllis. So again, now Rachel, you're up with what could accelerate the value-based care movement?
So I think what Phyllis said is absolutely 100% agree. It comes down to the patient, patient care, individualized, providers providing individualized care, and I think consistency throughout payers, whether it's through legislation or not, but just how so many different health plans are out there, like even in the MA side, and the difference between Medicare, the Next Gen, the MSSP, DCE, all of them. If there's some consistency with it, I think it drives providers to have more knowledge about how the program works, how they can succeed in the program. Whereas if there is no consistency, it's so much harder for providers or anyone to understand what they're supposed to do and how they're supposed to be successful. So I think consistency throughout the nation, not just geographically either, because I know there's so many different areas that have certain Medicare Advantage penetration. There's some have large amounts of Medicare Advantage, such as Florida, whereas other states are hardly any, and there's no value-based contracts in those. So I think it's just among that, having consistency throughout all the programs and not having them so different that people get lost in understanding it and can't actually do anything with it.
Thanks, Rachel. Brent, you wait.
Thank you. Kind of along the lines of what she was just saying, and also what Phyllis said. Whenever Phyllis mentioned policy, first thing came across my head was politics. All policy is driven that way. So, as value-based care, whether it's government or corporate placed, they need to keep in mind if they're the individual CMMI or Blue Cross or Humana, whoever that you have to deal with, that really all healthcare is local. You can't put a project together in Sparta, Tennessee that obviously is going to work in Cookville, Tennessee in the same way. So I think what they need to do in value-based care, and what I hope we will see, is them paring it down so we can understand the projects, the products, what we're going to be seeing. And once those are pared down, the implementation is going to be done at the local level. It'll be done at the local office. It can't be driven from a central source, whether it's Chattanooga, which Blue Cross is located in Tennessee, or in DC. They can't drive my practice and tell me what to do. It's going to work in my practice or your practice or your practice. So the fundamental plan of value-based care needs to be put in place, and they need to stand back and get out of our way. That's not the way to word that, what I'm about to say. But instead of our business, and let us implement it. Because we have implemented. John knows, we're a small ACO in Tennessee. We've saved about $75 million across our state for CMS and some private payers. That's pretty good. We seem to know kind of sort of what we might be doing. So put the process in place, stop changing things. Put the process in place and let us go.
I'm a little just concerned about time, but we'll take your question.
Well, I found that question interesting. I read it on my phone earlier because maybe it's just our practice. We're still in a very volume-driven environment. And I say that because we hire a lot of new physicians and we're growing our practice. It could take 2 years for them to see all value-based monies that are directly at them to really handle size. So the question is say that you have more time with patients are happy. Maybe you should start varying more life. We're just not seeing that. We don't have extra time. We're still 10, 15 minute time slots and moving. So I found the question was interesting, and maybe we're just companies said that 15 is all they have to see, but our goal is still 25 a day or more. So I just find the question somewhat interesting. Not sure how we get around new positions and have people look down. It'll still be volume driven for a while. I just don't know how it's going to change. So I don't know if it's a question or a statement, but.
So agree with you that it takes a couple of years for that value base. I mean, ACO, look at it, you don't get your shared savings payment until like 10 months after the calendar year ends. So I think to really make, the next question is about fast enough, and I have one of my notes is the ability to pay providers to not wait, 19, 20 months after, you see a patient potentially to get paid for it. It's just, you have to have more incentives quickly to get providers engaged. Now, engagement doesn't always come with just money, but it sure helps. And so I think, your ability to pay providers quickly, to have the short wins, the small wins, however you want to say it, to get them there is going to have to be a must to be successful for them long term.
I think I've heard other people say they prepay some of their providers out, maybe prepay is a little word, but they pay knowing that eventually they're going to do some benefit. And that might be fine if you've got big conferences or right, exactly, but if you're the physician that own it, you're taking from someone's pocket to put it in someone else's pocket. That's a little bit different, but that's a challenge.
Yeah, that was kind of what I was about to lead into is, if I take a doctor in my practice, I'm prepaid for their value-based care. It comes out of my business, it comes out of my pocket. A hospital is a little different. If you're Vanderbilt, you got a few $100,000 laying around, you can just throw at somebody. In Spencer, Tennessee, we don't have that. So it's I think this is just part of the evolution. It's trying to get to a point to where I said, we need to get these things in place so we can implement them. And, stop the changes. We're going to have to find a final point soon within the next 5 years to decide this is the direction we're headed. Because if we don't, it's going to start falling apart after that time. Because, that'll be 15 years into trying to move things into value-based care. If you're not moved there, it's not going to work. So you want to, and then whenever you prepay somebody, if they don't earn the money, then you run into real big problems, because I've seen that happen as well.
I wanted to read one response to that question that came from our advisory board members, and he won't mind me revealing who he is, but the respondent one to that question is David Klavanis, and many of you know that Palm Beach AC has been one of the most successful financially with the MSSP program. David responds this way, he says, value-based care has come a long way. It keeps some of us up at night thinking about the market threat of retail and other direct-to-consumer healthcare companies, Walmart, Walgreens, etc. And some of you heard some of that a little bit earlier. And their lack of value-based care vision. So this is just his perspective. Increased access to healthcare is great, but we need to think through who will take responsibility, accountability for patient populations. If direct-to-consumer companies provide services as the primary care physicians formally provided with no responsibility or accountability, health plans are going to need to increase compensation to primary care physicians for taking on higher risk patients that are out of the scope of the direct-to-consumer companies. That's just his response to it, but it's just another perspective that comes into play. One of the other advisory board members emailed me later after reading this himself, and he said, John, we're a long way from being on the same page. And I said, yeah, I agree with that, and maybe that's not all bad. Maybe we need to be able to have a diversity of opinions and responses to these things to proceed. Let me go to the next question. Okay. So this is a little longer phrased in the handout, but the same question. Despite tailwinds coming from COVID-19 in terms of cost pressures and heightened awareness of health inequities, CMMI has delayed the second application cycle for the global and professional contract models. Additionally, the actual results of the CMI's advanced payment portfolio showed that out of 54 total models, only 5 have produced statistically significant savings. Therefore, will value-based care policies, those are government policies, will value-based care policies move healthcare fast enough to secure the value-based care movement? And then secondly, how would Medicare Advantage play a role in advancing value-based care in the future? So this time, Rachel, we will start with you, and let's respond to that.
So as I said before, the ability to pay providers without, without waiting. But the second thing would be the ability for providers to take risk. And so if you're asking providers to take downside risk, you have to have that ability to do that. And a lot of smaller independent physicians do not have that. So kind of having, that ability to really harness the downside risks to jump all in, it's hesitant to a lot of providers. So without making it a little bit easier for your small one-doc independent practice, getting into downside risk is going to be hard, and so that has to get corrected before you see all the providers go into more value-based care or systems.
Thanks, Rachel. Brent, I believe you're up next to this one.
Sorry. Well, I mean, to me, some of it, just inherent in the question, goes to what I was trying to say earlier about, we're going to either have you find a highway and hit it or not. That's kind of what it says. Is the results out of 54 models, only 5 have produced significant savings. Well, I don't know. Maybe we should get those a little closer, possibly, and find best practices and how this works. A new doc coming out, and you have fast paced was the little group that started in our area for walking clinics. And I kind of see Walgreens doing the same thing and Walmart doing the same thing. I don't know if people ever really consider them their primary care office. Those locations will be where the green comes off the top. Like she was saying earlier, you're going to have to pay the primary care doctors additional revenues, which if you code correctly in value-based contracts, they kind of do pay additional revenues through your HCC scoring. So, people show up in fee-for-service in our area. I don't know what it's like in other areas, but in the state of Tennessee, 6 million people, so it's a pretty good sample. They go to the nurse practitioners, smaller offices, or they go to the walking clinics, or they go to Walgreens or Walmart or CVS Health or whatever's available for their sniffles or their simple to do things. Then they go to their primary care doctor for they consider the rest of the stuff that's important. And that's why we have to do the coding, do the everyday down and dirty work that we have to do as an ACO as physicians to maintain this. But I think inherent in that question is the answer to it. They found that some things that work, let's polish those things up and let them work.
Value-based care is not a one physician office practice, honestly. It just isn't. And so I am seeing several things happen working. DCE, I am starting to see people who have DCE license going out and signing up groups of physicians. You see large physician-led ACOs going after independent practice physician groups, whether they're small, medium, or large. So I think that in some ways value-based care and the proliferation of it is going to eliminate that solo or very small practice group, because I just don't think the resources are there for those groups to keep up and manage. As far as Medicare Advantage. I think there's some really great things out there, but I think there's also some not so great things about Medicare Advantage being the only game in town. So hopefully, what Brent said is that, you know, we find those 4 or 5 models and we really focus in on them, and we allow the community and the practicing providers in those areas to really advance care at that local level using those models. Because that's kind of what we all want, right? We all want that relationship with our primary care doc. We want value-based care because we know it brings good things. We don't want mega Medicare Advantage plans telling us always what to do. So it will be a fascinating 5 to 10 years on how this all plays out.
I realize we're running out of time, and you know, many of you already have scheduled appointments. So this last question is a very short question, also short answers, but I think it's also very important. I'm talking to a lot of our contacts and colleagues. So what information resources have you found helpful for advancing your field knowledge about value-based care? What information resources are helpful for advancing your knowledge about value-based care? And I've got one that I'll read here. It's a little self-serving, but the 4th respondent, who's also on our board, said, active participation in healthcare professional organizations, such as the American College of Health Executives and National Association of Health Services Executives, but also subscriptions to value-based resource materials, such as the ACO Exhibit Hall newsstand, that's us, modern healthcare, and she says, my ACO EH advisory board colleagues like these guys. So I think, again, those are some helpful resources. I will let you guys weigh in, and this time, Brent, you're our person.
You know, we found that attending, you know, gatherings like this are very helpful for us because we see what's happening in North Dakota and Texas and Florida and wherever. And we can carry back best practices to those locations. Our board is, for the most part, you know, as most boards are, for the most part, they stay up to date on this information that we send out to them. They're a really good source for us. And like John said, we always go to the exhibit hall, we see what's going on, we keep up with that. And we keep up with any printed materials. It's just like any other business space, you know, you've got to stay ahead of the curve because if you don't, you ever fall behind, it's real expensive to catch back up.
Phyllis, you're up next.
Okay. Ditto.
I can't really add too much, but I would say doing some of the things early on. We chose to do all-inclusive population-based payments when there was only 2 out of the 40 next gens that participated in that because we saw what was coming. We saw that direct contracting was going to make it mandatory to have some form of claims payment. So kind of doing things kind of on the early end of the curve. You learn a lot of things before it becomes mandatory. So we have a great 2 years of learning before next year when it in DC becomes mandatory. And I think the conferences, you're never going to be able to do everything that all the speakers are up here saying, right? Because I remember a couple of years ago, I was listening to, I think it was and saying, they're like, hey, we have 40 care managers. I was like, oh man, I would just love to have one. And now I have 45. And so now I'm like, okay, a couple of years later, it happened, but right then I'm like, yeah, I can't do that. But then eventually you get a little bit more and those ideas do come and you can fulfill some of those and pick out, little things that work.
Thanks, Rachel. Well, that was our last question. I want to encourage all of you to take a copy of the handout. If you didn't get one, it's on this corner table. It's also over in that corner table. And also, if you didn't get one, you can go virtually and put it in your tote bag. You can just pick it up that way. They're all available. And also encourage you, one final thing. These guys mentioned up here, The ACO Exhibit Hall, our company produces a weekly, every Friday, ACO newsstand. It's free, doesn't cost anything. All you have to do is just go to acoexhibithall.com and register for it, and it'll come to your email every week. So, I know it's 2 o'clock, and we've got a late start, but we're going to finish kind of early. Yeah, but we'll stick around for any questions that you folks may have if you want to come on and talk. Any of the panelists, that'd be great. Thank you for